So the last topic in this chapter is gestational trophoblastic disease. It is a group of tumor and tumor-like conditions that are characterized by the proliferation of trophoblastic tissues, and these tissues may have malignant potential. And the gestational trophoblastic disease is mainly divided into two types. The first one is hereditary palm mole. Second one is gestational trophoblastic neoplasia. Hereditary palm mole is also known as molar pregnancy, and it is a non-invasive type, and it includes the complete mole and the partial mole. Whereas the gestational trophoblastic neoplasia, they include invasive mole, choriocarcinoma, and a placental site trophoblastic tumor. The first one is the hereditary palm mole. Hereditary palm mole is also known as molar pregnancy, and it is the non-invasive type of gestational trophoblastic disease, and it is the most common gestational trophoblastic disease. And it results from abnormalities of the fertilization. And hereditary palm mole is characterized by cystic swelling of the chorionic villi along with the abnormal trophoblastic proliferation. And the risk factors for hereditary palm mole are previous history of molar pregnancy, maternal extreme of age, means advancing maternal age, maternal blood group A, and the diet that is low in beta carotene and folic acid deficiency. Next is the types of the hereditary palm mole. So it is divided into two main types. First one is complete mole and second one is incomplete mole. Complete mole is also known as androgenetic mole, and it results from the fertilization of an empty ovum having no maternal chromosome by a haploid sperm, which then duplicate its own chromosome. So when the paternal chromosome duplicates, they shows 46 XX copy, means that they have diploid karyotypy, and all the villi in case of complete mole are edematous and vessels are absent in these villi. And in case of complete mole, the trophoblastic proliferation is diffuse and circumferential, and there will be no petal parts present. Hence, the embryo in case of complete mole is not viable. And the serum and tissue human chorionic gonadotropin levels are markedly elevated, and there are about 2% chances after transformation into the choriocarcinoma. In case of complete mole, the uterus size is more than period of gestation because of the excessive proliferation of trophoblastic tissue, and the ultrasound shows snowstorm appearance of the gestational sac in case of complete mole. So in complete mole, there is fertilization of an empty ovum by a haploid sperm, which duplicates its own chromosome, and they have diploid karyotypy. Second one is the incomplete mole, which is also known as partial mole, triploid mole, and incomplete mole. They result from fertilization of an ovum with the haploid set of chromosome by two sperms, which have two sets of the haploid paternal chromosome. So when an egg having haploid chromosome is fertilized by two sperm, it results in a triploid karyotypy, means that they have 69 chromosome. And in such case, some villi are edematous and vessels are present in these villi, and the trophoblastic proliferation in case of partial mole is focal and slide, and the embryo is viable for a few weeks in case of partial mole because some fetal parts may be present, and the serum in the tissue HCG is slightly elevated, and the transformation into a choriocarcinoma is uncommon. In such case, the uterus size is less than period of gestation, and an ultrasound, there are signs of a mass abortion. Next one is the presentation or the signs and symptoms of the hereditary palm mole. So the most common and classic symptom is first trimester vaginal bleeding. Similarly, the uterus is large for the gestational age, and there is vaginal passage of the vesicles, which contain the product of conception. And the passage of vesicles per vaginally is the most classic symptom of hereditary palm mole, and there is an abnormally elevated high level of beta HCG, more than 1 lakh international unit, and there are exaggerated signs of this pregnancy, like there is hyperemesis gravidarum, which is pathological form of vomiting, signs of hyperthyroidism, and there is early preeclampsia occur. And the investigations that we do for the hereditary palm mole are serum beta HCG level, which is more than 1 lakh international unit. We do full blood count, in which we assess for the anemia and the thrombocytopenia. Similarly, we also do coagulation profile, in which we check the PT and INR to assess for the coagulopathy. Similarly, we also do the liver function tests, blood urea nitrogen and creatinine. We also do blood grouping and determine the RH factor, and if RH factor is negative, We give anti-immunoglobulin. Similarly, we also do thyroid function tests, in which we check the TSH level, T3 and T4 level. Similarly, we do serum inhibin level, inhibin A level and serum activin A level. Both are increased in the gestational trophoblastic disease. And we also do chest X-ray in case of invasive disease for the metastasis. And we also do the ultrasound, which is the diagnostic method of choice. In partial mole, it may show viable fetus. It may show signs of a mass abortion, but in complete mole, it shows snowstorm appearance, which is a diagnostic sign. And the snowstorm appearance is because of the hydropic villi and intrauterine hemorrhages. Next is the treatment of the hydatidiform palm. Also, suction, dilation, and curettage is the treatment of choice. And in case where the female had completed their childbearing, we can also do hysterectomy. And for the follow-up, we do weekly beta HCG titer until within normal range for 3 consecutive weeks. And then we do the monthly beta HCG titer until within normal range for 6 consecutive months. And the normal level are usually achieved within 8 to 12 weeks after dilation and curettage, and the level of beta HCG should consistently drop and should never rise. If the beta HCG level plateaus or rises, then the patient is considered to have invasive or malignant disease, that is the gestational trophoblastic neoplasia. And the woman should be advised to not conceive until the beta HCG titer reaches the normal level within 6 months, and the barrier contraceptive should be used until the serum beta HCG is normal. And the second type of gestational trophoblastic disease is gestational trophoblastic neoplasia. Means that it is an invasive disease and there is a proliferation of the trophoblastic tissues that have malignant potential. First one is the invasive mole. Invasive mole occur after hydatidiform mole or the mole of pregnancy, and it is characterized by the abnormal proliferation of trophoblastic tissue and the penetration of the uterine myometrium by these tissues. Second one is the uterine choriocarcinoma. So the choriocarcinoma is an epithelial malignant neoplasm of the trophoblastic cell, and it can arise from any type of the trophoblastic tissue. That is, it can arise from the cytotrophoblast or the syncytial trophoblast, and it is the most aggressive type of gestational trophoblastic disease and having early metastasis. And the risk factors for the choriocarcinoma is hydatidiform mole, previous abortion, normal pregnancy, and the ectopic pregnancy. But the most common risk factor is previous history of a abortion of the hydatidiform mole. The third type is the placental site trophoblastic tumor. So it is a malignancy of the intermediate trophoblast, and it is usually found at the site of implantation in the placental membrane, and it accounts only for 2% of the gestational trophoblastic neoplasia, and it is associated with elevated level of human placental electrogen and the high level of beta HCG. And these two markers, K67 and Malcolm biomarkers, are used to differentiate it from the normal exaggerated placental implantation site trophoblast. And the risk factors for placental site trophoblastic tumor include normal pregnancy, spontaneous abortion, and the hydatidiform mole. And the signs and symptoms of gestational trophoblastic neoplasia are vaginal bleeding, amenorrhea, and the symptoms that are suggestive of metastasis are, in case of lung metastasis, there may be dyspnea, hemoptysis, and the chest pain occur. In case of vaginal penetration, there may be vaginal bleeding and discharge occur. In case of CNS involvement, there may be neuropathy, headache, and stroke-like symptoms. And in liver metastasis, there may be epigastric pain and jaundice occur. And metastasis occur to the lungs most commonly. In 70% of the cases, there may be metastasis to vagina, central nervous system, liver, and the spleen. And the investigations that we do in case of gestational trophoblastic neoplasia is ultrasound, serum beta HCG level, and chest X-ray. In case of the metastasis to a lung, there may be cannonball appearance occur. And similarly, we also do CT, abdomen, chest, and pelvis for the staging of the disease. And the staging of the gestational trophoblastic neoplasia, we divide it into 4 stages. And stage 1, there is elevated beta HCG, and the disease is confined to the uterus. In stage 2, the disease extends outside the uterus, but still it is limited to the pelvis, that is to the adnexa and the vagina. And stage 3, there is metastasis occur to the lungs. And stage 4, there is metastasis occur to the extrapulmonary site or the pelvic locations like CNS. On the basis of staging, we divide it into the low risk and the high risk gestational trophoblastic neoplasia. Low risk gestational trophoblastic neoplasia have good prognosis, and they include the stage 1 disease, stage 2, and the stage 3 disease, but who WHO score is less than 7, means that their age is less than 40, the CMB/CG level is less than 40,000 international unit, and the time interval from the pregnancy to the chemotherapy is less than 4 months, and tumor size is less than 5 centimeter, and they show good response to the previous chemotherapy. And high risk gestational trophoblastic neoplasia, they have poor prognosis, and they include stage 4 disease, stage 2 or stage 3 disease, but who WHO score is more than 7, means that their age is more than 40, CMB/CG level is more than 40,000, and the time interval from molar pregnancy up to a chemotherapy is more than 4 months, and there is metastasis occur to the liver, CNS, kidney, and the largest tumor is more than 5 centimeter in size, and there is a poor response to the previous chemotherapy. Last is the treatment of the gestational trophoblastic neoplasia. So the first one is the low-risk gestational trophoblastic neoplasia, which have good prognosis. We give single-agent chemotherapy, and the most commonly used drug is the methotrexate, which is a folic acid antagonist. And alternative agents that is given as a chemotherapeutic agent is actinomycin D when the methotrexate is contraindicated. And the goal of the therapy is to achieve remission, which is the 3 consecutive weekly beta HCG titer within normal range. And once remission is achieved, then monthly beta HCG titer should be done until negative for 12 consecutive months, and the follow-up is done after 1 year. And the follow-up should be done for 1 year. In case of the high-risk gestational trophoblastic neoplasia, which have poor prognosis, we do multiple agent chemotherapy that include etoposide, methotrexate, actinomycin D, cyclophosphamide, vincristine, and the leucovorin. And the goal of therapy in such cases is to achieve remission, which is a 3 consecutive weekly beta HCG titer within normal range. And once remission is achieved, then monthly beta HCG titer should be done until negative per 12 consecutive months, and follow-up should be done per 1 year. So it was all about the gestational trophoblastic diseases.